Awesome. Thank you. All right. Um, all right, we'll go ahead and get started. Hello and welcome to our webinar, Tics and Tourette's, How to Talk to Clinicians and What to Expect. My name is Marissa Shu, even though it says Brenda Parrott on the screen, I am Marissa, and I'm a program lead at the Tourette Association of America, and I will be your moderator. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During the webinar, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments using the comment section at the bottom of the screen. All questions will be addressed during the Q&A session at the end of the presentation. I'd like to mention that funding for this webinar was made possible by our cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial product practices, or organizations imply endorsement by the U.S. government. At this time, it is my pleasure to introduce our speaker for this webinar, Dr. David Sprecher. Dr. Sprecher serves as Movement Disorders Director for Banner Sun City Research Institute, and he's also the co-director of the Phoenix Tourette Association of America Center for Excellence. He is a neurologist specialized in clinical care and research for movement disorders, including tics and Tourette's. Before moving to Banner Health in 2015, Dr. Sprecher served at the University of Utah as Movement Disorders Division Chief and co-director of their Tourette Association of America Center of Excellence program. He completed his osteopathic medical degree at Lake Erie College of Osteopathic Medicine, medicine internship and neurology residency at the University of Utah, and fellowship in movement disorders and experimental therapeutics at the University of Rochester. Inspired by personal experience as an individual with Tourette syndrome, he has dedicated his career to improving treatment options and quality of life for movement disorder patients. Without further ado, Dr. Sprecher, please go ahead and you can begin your presentation. Thank you.
All right, thank you so much for the opportunity to speak to the community at large. As you heard, I'm really motivated by my own personal experience, and I wanted to share with you my own perspective, not just as someone who knows what it's like to have tics and Tourette's, but someone who's one of our national specialists that sees a lot of patients through their journey, through diagnosis and their lifespan with Tourette's. So wanted to take time, whether you're a young adult, a kid, or just a parent who's concerned about their kid with Tourette's, to just give you some advice. How do you prepare to talk to your doctor, your primary care, your therapist at a first visit or at a follow-up visit about what symptoms you're going through? And then also, just when they give you advice about what to expect, I want to give you a little bit more detailed perspective about what to expect with tics and Tourette's. For me, I grew up in the 70s and 80s, and there wasn't an internet yet. We had dial-up. We could play Dungeons and Dragons on little dial-up modems. That was about it. But there wasn't a lot of information when there's something weird going on to just Google it or search it on ChatGPT nowadays and figure out what it was. But I definitely remember even in first grade, I would just sit there making these funny noises, and another girl next to me asking me to stop doing that. And I didn't realize that it was something that bothered other people until they said something. And then I remember, this is me about in fourth or fifth grade here with the glasses, and I would constantly be doing this thing, scrunching my glasses, and one of the other kids making fun of me for it. And I didn't realize at the time those were things that nowadays people are more aware. We would call it tic, but it definitely got to be more of a problem as I got older, where tics were more pronounced. But for me also, they talk about comorbidities, and that's something I wish I had known more about growing up as well. And I want to take time to share with all of you, what are some of the other things more common in people who have tics and Tourette's that we're going to be watching for, and we need your help so that we can figure out if you also have these other conditions that tend to come along with tics and Tourette's. So this isn't what Dr. Tourette actually did. He didn't have Tourette's, but if he did, this is what it might have looked like. He has in the video the same movements over and over again. So you can see he bobs his head, he shrugs his shoulders, he scrunches his nose, he moves his eyebrows up and down. But if you keep watching him, you're going to see the same movements over and over again. If there were audio, you might hear the same sounds over and over again. So that's what we call motor and vocal or phonic tics. Now, the tricky thing is the normal, healthy, developing brain in a kid can have some tics. So it's really common if you sit in a classroom and watch for these, you're going to see them. But for many people, they're only present for a few months at a time and then they go away. So when you first go to your doctor, this is very often you go to the pediatrician and they'll tell your parents, they'll say, this could turn out to be Tourette's, but we need to watch it for at least a total of a year of having these before we can call it either chronic motor or chronic vocal tic, chronic phonic tic, or if you have both, we would call it Tourette's syndrome. But the other things that they may ask you about are what we call the comorbidities. And the top two most common that majority of people with either chronic tics or Tourette's will have are obsessive compulsive disorder or attention deficit with or without hyperactivity, so ADD or ADHD. More than half of people will have two or more of the things on this list. So that doesn't necessarily mean that 57% have OCD and ADHD, but at least two or more of these symptoms on that list. So it can also include problems with depression, problems with anxiety, and also problem behaviors. And in kids, we call it oppositional defiant disorder, but in adults, they have a different name for it. But it's still temper tantrums are a big problem in kids and adults, where people have more trouble controlling their emotions and acting on impulse when they feel upset. So that can be a disorder that's more common in people with tics and Tourette's as well. So these are the kind of things that we're going to need your help, weighing in about if you've noticed things that fit along these lines. So today I'll talk you through some of the common things that we're looking for to decide not only if you have a tic, but also if you have one of these, what we call psychiatric comorbidities. And most of the studies that were done that pediatricians and other clinicians used to tell parents and their kids what to expect are from two main places, the Cleveland Clinic in Ohio, and then Yale on the East Coast. And these are pediatric clinics that have been seeing a lot of tic and Tourette patients since the 70s and 80s. And in the 1980s and 90s, they published these studies that found in their kids that they followed until they were young adults, 50% felt like they were nearly tic-free, so they barely even noticed tics anymore by the time they were young adults in their early 20s. About a quarter had some improvement, but then a quarter stayed the same or got worse. So based on that, pediatricians, other clinicians used to tell families and their kids, you're probably just going to outgrow this, so don't worry about it, but if it gets worse, come back and see me about it. And what I'm starting to learn now that I've seen a lot of people and families with tics and Tourette's is it's better that we don't just leave it to chance, but we just schedule to check in within a year and see, did it get worse before it got better? Did any of these comorbidities start to become more of a problem or become a problem rather than the tics? Another tricky thing is that even though we were telling people you're going to outgrow this, in the early 2000s in Rush University in Chicago, They did this study where they did a video of these young adults who felt that they had become tick-free. And then they sent the videos to movement disorder experts to watch the videos and watch for those tics, same kind of movements and sounds over and over again. And 90% of the people who felt they were tick-free still had tics that an expert could notice. But the good news is these people were still dramatically better than when they were kids. But it's an important thing to understand that it's not that you outgrow it, it goes away and you don't have any tics, but chances are they're going to improve or you're going to learn how to manage them. We also, when I was starting out at the University of Utah, tried to follow up people who had participated in research on genetic causes of Tourette's, looking for genetic causes. And it was a little tricky to find people who had participated as kids who are now young adults, because we were basically starting a new study. People hadn't really kept in touch, so it was hard to track them down. We were having to go online and pay to do little searches to get a hold of people, find where their phone numbers were. But we found 10 people who were willing to be contacted and then come back in for interviews and even MRI research. And what I found of those 10 people we got a hold of, 2 of them had improved, but we really didn't find anyone who was 100% tick-free. So just to reinforce what I said earlier, it's common to see improvement, but just not necessarily that they go away 100%. The other problem is all these studies I told you about so far are all studies of boys who then became young adults. But we don't have enough long-term studies in girls to say whether those same percentages are true in girls when they become young adults. Tourette's is a lot more common in boys than girls. About 4 or 4.5 times more boys are diagnosed with tics and Tourette's than girls. However, even though there's 4 or 5 times as many boys as girls in the child neurology clinics with Tourette's, in the adult clinics, there are about 2 men for every 1 woman. So that kind of tells us there might still be more women who don't have as much dramatic improvement in their tics and come to attention of neurologists. It may be that girls have a different course, and so we need to watch a little bit more carefully for how the tics evolve as they get older and how to come up with strategies to manage not just the tics, but the other things that come along with. So people ask me, what causes tics and Tourette's? And one of the simple answers is just that your brain is wired a little bit differently than someone who never had tics or Tourette's. As your brain is developing, it's common for you to have some tics. So that is a normal part of the way your brain kind of matures when you're still a kid. But in people with Tourette's, your brain doesn't fully mature in a way that these movements and sounds go away. And so you continue to have them and this urge to do them. There's also a genetic predisposition to this. Most people start to notice their tics, or other people start to notice their tics at an average age of about 6 years of age, 6 to 8 years, plus, 6 years plus or minus 2 years. Another important thing to understand is most people will have a peak in how severe their tics are between the age of 10 and 13. And a lot of times this happens right after an infection or after starting a new medication. And people seem to blame that event, the thing that happened or the medication, for that increase. And it's really the natural course of the tics. So just because you noticed it when you started a new medicine doesn't necessarily mean that it made that permanently worse. We want to coach people and know to watch for this. So if you know someone who's still under age 10 and their tics aren't bothering them now, we just want to know we need to watch carefully for it becoming a problem as they start getting into those tween years. When people notice improvement, it's usually in their late teens or early 20s. But there are a lot of reports, even in people first noticing this at age 60 or older, of people who had dramatic improvement in their tics, but then as an adult, often during a stressful time in their life, the tics came back and they never completely went away. We don't fully understand why that can happen, but it's important to be prepared that it may happen. And so we want you to have strategies of how to manage this situation if the tics come back. So I've been in the position, and this is something many of you either have been or are going to be in the position as someone who has tics that were very pronounced and somewhat of a problem as a kid. So you definitely had Tourette syndrome, but now you yourself have a child, and now your partner, or in my case, my wife, were really worried about your kid having something that might be a tic, might be something else. And in our case, this is one of the common situations. It was a lot of kind of huffing and throat clearing. So, my wife was worried my daughter maybe had asthma. But what you'll see in the video of her, this is when, let's see, she was about 6 years old and she's 20 now. So this is a while ago, but I got her permission to use this for the video. This is her when my wife was worried about her vocal tic, what I was pretty sure was a vocal tic, but you're going to see she also has a bit of a motor tic. So this is an example of what a motor tic can look like. She's doing this thing with her nose. Do you have an itchy nose, sweetie?
No. What can it feel like?
Hmm?
Just a second. When I checked the feeling, I wish it was like a real upper. I have a piggy nose, that's why. Anyways, no. I'm not sure what these are made out from, but.
So the point of showing this video, it's a cute little kid and she's having a tic. She's not aware of it. She's not bothered by it. And I can tell you, she still had tics even when she was about 8 or 9 years old. I remember kind of sitting next to her, reading together, and she was doing some motor tics. But as a teenager, they did go away. And I can't guarantee this will happen for all of you, but it can happen. And, I never told her, hey, this is Tourette's, you're just like me. We just called it a minor tic and, we let her know that's what it was, but she outgrew it. And for some people, it really helps to have that term to tell people this is a form of Tourette's. Not everyone with Tourette's has cursing tics. And to be able to explain it to people, it helps to have that name to put on it. But for a lot of people, that label, it can lead to unnecessary kind of singling out, what we call stigma, or even bullying, or just misunderstanding with the teachers, where they're kind of giving people a lot more accommodations than they really want or need. So I recommend, talking it over with your clinician, whoever it is that's giving you a diagnosis, about whether you feel comfortable using that term. And if you feel like you're doing really well with it, you don't have to tell everyone this is Tourette's. You can just say it's a nervous tic. This is just something that I do. And don't be worried about me. I can't always control when I make this humming noise or scrunch my nose. If I roll my eyes, I'm not rolling them at you. It's just my tic. But not everyone needs to have that label of Tourette's, is what I'm trying to say. Another important thing in preparing for visits with the clinician is being prepared to share a little bit about family history. We don't necessarily need this to make a diagnosis, but it helps give us a sense of what symptoms to be watching for. we call it the Tourette triad. Dr. Jankovic at Baylor, one of the most experienced people in the field, came up with this term. The Tourette triad are the three most common conditions that are often inherited together in families. And not everyone has all three. Some may have one, some may have the other. But those are the tics, the obsessive compulsive symptoms, and the attention deficit with or without hyperactivity. And what he found in his clinic, his team published this study in the end of the 2000s, is that 84% of children with Tourette's had at least one parent with one of these triad symptoms. And a quarter of the kids, both of their parents had at least one of these symptoms. Tics were more common in the fathers and what we call the obsessive compulsive symptom. So either having rituals they have to do a certain way or over and over, or thoughts that they really have trouble shaking, or they have to do things a certain way or think about things a certain way, it really bothers them. Those obsessive compulsive symptoms were more common in moms. In fact, there were some families where if they considered obsessive compulsive symptoms and tics to be part of the same gene or the same condition, they found that it really seemed to run in families very strongly, whether it was in men or women. But if they just considered OCD as something different, then the women didn't seem to be as likely to inherit the condition. So basically, women only inherited tics about half the time compared to men. But if we consider OCD anxiety to be equivalent to tics in those families, then everything's inherited equally. So 50% of each family member would inherit one of these conditions. That said, to date, there's only one family where we've actually, to my knowledge, identified a specific gene that explains it. It's in a gene called histidine decarboxylase that's responsible for histamine in the brain, histamine production in the brain. But in most families, we think there's more than one gene involved, and that's why it's going to be a lot more complicated to predict who's going to have one of these symptoms in a given family. However, one of the other important pieces of information for people who first notice their tics or first develop tics that are a problem as a young adult, one of the most important things to talk to the neurologist about, and usually you're going to see a neurologist for adult onset tics, is if you have a personal or family history of either tics, OCD, or ADHD, meaning if you had these as a kid and then outgrew them, and it could be you had OCD as a kid and now you have tics, that still may explain it. Similarly, if someone in your family had tics, OCD, or ADHD, and you were not diagnosed with tics as a child, you're still genetically predisposed to either of those three things. And it may just be you didn't notice them as a kid, but you definitely are noticing them now as an adult. Not all adult onset cases turn out to have a genetic explanation or tied with a childhood history of one of those triad symptoms. But in my experience, the majority are in that setting. We'll also talk about some of the other things that can be mistaken for tics that also start in adult years. And I think those may start to explain majority of the remainder now that we better understand what we call the functional tic disorders or functional movement disorders. So when you come into a neurologist's office, that's usually because your primary care, like your pediatrician, for example, is looking for a second opinion, or maybe you're seeking it out because you want to see a tic Tourette specialist. What we're going to be looking for, and it'll be helpful for you to help us understand this, both in your history that you give us, the details you provide, but even with videos, if these don't usually happen in the doctor's office. First of all, is it the same movement or the same sound or the same words over and over again? Or does it vary a lot even over the course of a day? Because the typical Tourette type tics are stereotyped. It's the same ones over and over. New ones may appear over time, over weeks to months to years, and old ones may go away. but it doesn't usually cycle into different tics over the course of a single day. Now, it's not something that has a steady rhythm to it. So a lot of people will shake their leg up and down because they like to fidget. And that can be seen in normal, healthy people that just are a little bit hyperactive or just like to keep moving. So some people normally have rhythmic movements in their legs. That's not what we're looking for. A lot of people also have a bit of a tremor in their hands, and there are a lot of other explanations for that. Those are examples of things that are rhythmic. Tics are more common in people who have something on that autistic spectrum. So even high functioning autistic people may have rocking or humming behaviors where it's kind of the same thing over and over again, and it can have somewhat of a rhythm to it. And that's not necessarily a tic. It can be something called a stereotypy. So this is where describing all the extra unwanted movements to the neurologist are going to be important to help us decide what's a tic and whether you can have more than one thing going on. With tics, most people will, by the time they're at least over the age of 10, notice that if they try, they can hold back the movement. So tics are suppressible, but kids under age 10 may not recognize that ability to suppress it. But 90% of people over age 10 are able to suppress to some degree. The urge will still build up and may be uncomfortable for some people. And the other thing is the urge. So it's this feeling right before the tic. Many people describe it as a feeling like they just had to do it, but a lot of people say there's a building up of energy, or there's a tightness, there's just something you have to release. And that urge is also seen in most people, 90% of people over age 10, but not all people under the age of 10. So being able to describe if you can suppress or if you have an urge is important to help us decide if that's a tic. We say that tics wax and wane, kind of like the moon does. And you'll probably also notice with tics that they're worse during stressful times, but also exciting times, like right before school starts or right before winter break or right before a trip to Disneyland or Disney World. So if you have something or you're not sure what it is and you want to show a neurologist, bringing it on a tablet or a smartphone and being able to show that video can be really helpful for the visit. I'd say the most common reason after those, what we call stereotypies, that people with developmental delay or autism, Down syndrome may have, after the stereotypies, probably the most common is a tremor. So many people have a little bit of a tremor as well, and it can be side effect of medicine. It can be normal physiological tremor that most people have, but notice more when they're excited or anxious. But after those two, the next most common, and it seems to have become a lot more common during the pandemic, are what we call the functional neurological disorders. These can resemble seizures, so we call them non-epileptic seizures when it looks like a seizure attack. And they can resemble tics and other movement disorders, but the main difference is it comes on like an explosion out of nowhere, really severe all of a sudden. And there's a lot more variation in the movements and sounds. It also very often includes reciting lines from movies or from things you've seen on social media of other people that are showing video of their movement disorders. It's very unusual for people with run-of-the-mill tics to have words and phrases that constantly quote movie lines. So when you see that and it comes on really suddenly, and there's over the course of the day a wide variety of movements and sounds, it's very dramatic. That often gets us thinking about something called a functional movement disorder, a functional tic disorder. And it's really important that you try to avoid watching lots and lots of videos of these movement disorders, because I know you're curious and you want to learn about what you have, but the more people watch it, it seems to add to their repertoire and they get more and more of these movement disorders. So functional tic disorders, it's a subtype of functional movement disorders, are very common in teens and young adults. So in someone who starts to have very severe tics and tic attacks in their very late teens or young adult years that never had tics as a kid, that could be a functional tic disorder. Doesn't mean that we don't still need to see a tic and Tourette team and consider a combination of medication and behavioral therapy, like we'll talk about. But it's a different diagnosis, and we have to approach it a little bit different than run-of-the-mill tics and Tourette's. Now, with all of these, what we want to hear from you, the kid, so the child, the adolescent, the teen, even the young adult, we want to know from you, why are you here? And we know a lot of times people come in part because their parents are worried about them. But a lot of the times, if you think about it, there's something about either the tics or some of these other comorbidities, once we identify them, that are bothering you. And one of the most common reasons is just people don't like that they have it and that it makes them different. They feel like they're being singled out by other people. They're just different. And it affects their self-image and just their overall happiness. And that's something that's important, and we want to hear about that and help you with that. It might be affecting how you're doing at school. And in some cases, if you don't already have an individualized education plan, we'll write letters to support something called a 504 plan. So you might get extra time to take your tests, or you could take tests in a different room. We can ask the school to make sure teachers are trained on how to work with kids with Tourette's, so you're not punished for things that you can't help. And real important thing to hear from you is how the tics are just affecting you in your everyday life. Are you being bullied, or do you feel like you're being punished for something at school or at home that you can't help? Are the tics just embarrassing, and is it hard for you to just cover it up and just pretend you were itching, or pretend that your eyes were bothering you when you're having a face tic, for example? And this is where it's challenging, is with the tics start to bother or distract other people at school or even at home. We still want to talk through how we can manage that. Some people actually have pain from their tics. They hurt their neck. They may be jabbing themselves, where they actually hurt themselves from doing, from the tics directly, or just they're so tired from doing the tics over and over. Some people, though, if the tics are really severe and they're at high risk of causing serious injuries, or the tics cause you to hit other people or break things, that's where we sometimes need to talk about more effective treatments that include medicine sooner than later, because just doing education of people around you or just the behavioral therapies alone may not be enough to prevent these other problems. When you grow up, though, tics may still interfere when you're in college, or you go on a religious mission, or in your first jobs. And so we still want to be able to talk about how the tics affect you at work. And sometimes before you even start pursuing a career path, are there some types of jobs where it might not be practical for us to tell the workplace that you need special accommodations? The workplace is required to provide you reasonable accommodations, but in many cases, there's only so much you can do. If you're a used car salesperson, you can't tell the customers they can't look at you differently if you're taking and rolling your eyes all the time, but you can learn sometimes how to manage that and joke about it. There's only so much you can do. If you're a massage therapist and you can't help that you're constantly poking the person with your fingers from your tics, there's only so much we can do. We can't tell the customers that they just have to learn to accept you for who you are. But in most careers, there are special accommodations that can be made where we ensure that people aren't being singled out or punished for tics they can't help, but we just need to be practical about making sure these are reasonable accommodations. So when you're preparing to go to see a healthcare provider, it really helps to upfront, even if you have to interrupt the doctor, just tell us, why are you here? I mean, we should start the visit by confirming what you're looking for coming there, but sometimes we forget to ask. But try to have one main goal that you make sure you're clear about and you accomplish. It could be that I want to make sure that I leave the visit with that 504 plan letter, because I feel like I'm having trouble at school. That could be the goal. And then we have another goal for the next visit. But make sure you communicate that and be prepared. When we ask you the question, what is the main problem? Is it the tics? Is it depression, anxiety, OCD, ADHD? What if you had to address one thing first, what would it be? And there are some forms, if you can do them ahead of time, we can give you better advice. One important example is many of the pediatric clinics and some of the Tic Tourette clinics will ask you to fill out a screen. Usually it's the parent and also the teacher that complete their own versions of this. Sometimes it's the young adult screening for possible ADHD. In our clinic and some of our partners here in Phoenix, we use the Vanderbilt ADHD screen. So publicly available PDF that we'll send ahead of time. And it really helps if you have that completed ahead of time. Also having a list completed ahead of time where when we ask what medicines you're taking, but what you tried before and what didn't work out, if you're able to send that ahead of time, it can save a lot of time. So then we have more time in the visit to address your needs and your concerns. And it helps to know up front, some people have reservations about medication or are really interested in CBIT, the behavioral therapy. And it helps to know that up front so that we can tailor our advice accordingly. But it's also important to come with an open mind that when things are really severe, you may need a combination approach. Okay, so other thing that helps me to know is if someone has already done some type of behavioral therapy, either for tics or OCD, if it worked or it didn't work, what was it like? And if it didn't work out, what about it did you feel was not effective? And we can help you understand if there's a different way of going about it that other people we might refer you to could do differently. So it helps to ask about CBIT because very often, even though the Tourette Association of America tries to keep an up-to-date list of certified CBIT providers, some are the ones we tend to refer to, and there's a reason for it. And a lot of times it has to do with affordability or experience. So make sure to ask about if we don't bring up CBIT and you're interested in it, ask about who we can recommend in your area. And there also may be online options. We'll try to update you about the online options because those can change over time. Sometimes clinicians will prescribe something that's not on this list or that's not on the list of recommendations on the Tourette Association of America web page. And if you're going to a Tourette specialty program, that's not going to happen. But sometimes we'll hear about medicines that aren't on the typical list. So this is a video recording. I have, the most common ones, the ones that all doctors would agree have evidence that we can recommend for tics and Tourette's. And so if you've never been, talked to about medicines on this list, that's where, if you've never been to a tic Tourette specialty clinic, it's important to consider getting a second opinion. Very often, primary care docs will do the best they can and treat you with the medicines that they've learned about, but they may not be familiar with all of the medicines that have good evidence that they're effective for tics and Tourette's. One important thing to ask about, though, if you have ADHD as well as tics that are, bothersome but not severe, where you're hurting yourself, clonidine or guanfacine are medicines that you might want to talk about, particularly if you have trouble sleeping at night, because nighttime dosing can also help with sleep. If you also have migraines or epilepsy, then it is worth asking if topiramate could serve as a dual therapy to prevent migraine headaches or to also treat your epilepsy. It's not always appropriate for your situation, but it still helps to ask about, because I've sometimes had referrals from people managing someone with these conditions, and they just hadn't thought about switching to the topiramate. The antipsychotic medicines, these are examples of the ones that you often will see from the movement disorder clinics. Notice I don't put haloperidol or Pimozide on there because even though they're FDA approved for tics, most would agree in the movement disorder clinics Aripiprazole, which is Abilify, risperidone, and flufenazine tend to be better tolerated. The important thing about antipsychotics is to keep an open mind. These are more potent tic-suppressing medicines. They are much, much less likely to cause movement disorder side effects if you're taking it for your tics. There's lots and lots of years of experience, decades of experience, where it's very clear tardive dyskinesia, which is a permanent movement disorder side effect that may not go away even after you stop the medicine, is very, very rare in people taking it for tics, but it can affect at least 7% of people who are taking it for other conditions like mental health conditions. Tetrabenazine, Austedo, and Ingreza are medicines that may be used off-label, and they're expensive, but it's okay if your doctors are recommending these. It's just we may want to start with something that's easier to get approved by insurance. And if you have really severe tics where you tend to hurt yourself, particularly with neck tics, then injections like Botox or some of the other ones in that same family as Botox also are now recognized as a standard treatment. And we usually can get insurance to approve it when we cite those recommendations from the consensus groups. So we're going to wrap up in a moment, but I just want to touch again on the comorbidities that I mentioned earlier. I think it's important to be able to tell us if you have things where you have to do them over and over or do it a certain number of times, things that are like rituals, like going back, checking the lights are off, even you turn the lights off, to tell your clinicians, are you doing it because you feel anxious if you don't? Some tics kind of have a compulsive quality because you have to do it a certain way, certain number of times, or do one side then the other, but it's still in response to an urge. And so it's still a compulsive tic, but compulsions are things you do to relieve anxiety. And obsessions are thoughts that you just can't shake once you start thinking about it. And it can really interfere with sleep or just take tons of mental energy and interfere with school or work. So these are important things to bring up with the clinician because it's a lot more common, obsessive compulsive symptoms and anxiety in people with tics and Tourette's. And a lot of times people get depressed, whether they have Tourette's or not, but it's important to bring it up if you're just feeling sad, hopeless, just going over in your mind, feeling guilty about the past, and bring that up with your clinician. And if you're seeing a neurologist, but you're really depressed, it's important that you also let us get you in with someone who's a psychiatrist or psychiatry provider, and even a talk therapist. For depression, anxiety, OCD, talk therapy is really, really important. And I can remember being kind of annoyed that I was going to someone that I felt was being like paid to be my friend, but they're not being paid to be your friend. They're really like a life coach, but someone who really knows how to help you recognize when your thought process is making things work and pulling you down into that depression, letting you get too anxious, more anxious than you need to be, or wasting tons of time and mental energy on obsessions and compulsions. So talk therapy is a very important part of treating these comorbidities. And it's really important that if your parents' insurance has a different part of their plan to get in with a talk therapy person, that they make sure they find out who's on the plan and help you find someone you're comfortable talking with. Because these coping strategies are going to be so important for you when you get older, and they work for you the rest of your life. If you really have trouble keeping still or paying attention when things are going on around you and you just get distracted, then you could have attention deficit or attention deficit hyperactivity disorder. And if it's severe, but you really want to be in a traditional classroom, we can make some accommodations, but it just may not be possible to be successful as you get into high school and then on to college without some type of medicine to help you focus better. So it's important to keep an open mind about medicines if the ADHD is really interfering at school and you're planning to get into a career path that requires the traditional education program. You can go into vocational schools with untreated ADHD, but you're probably not going to get into medical school or law school, for example, without being able to treat and manage ADHD. There's just too much studying and need to focus, for example. There's exceptions to every rule, but most people will need at least some treatment to get through that. And then finally, this is another area, anger management problems. Often dads have a problem, then their kids have a problem with temper tantrums, and then going together and having that talk therapy and learning how to manage anger and temper is something that can help as a family, but also really important to start addressing that with behavioral therapies when you're a kid, because then you learn it as a young adult, and it's a lifelong learning. People continue to learn how to manage it, and it's just something that never too late to start. And it may be that when we choose tic medicines, the medicines for tics also help with the disruptive behaviors as a kid, or the temper control, anger control problems as an adult. So keep an open mind of both about talk therapy approaches and medicine. And most people will have improvement as they grow up. But for most people, Tourette's and tics are still something you have when you get older. You just learn how to manage it. And if it starts to get worse when you're older, it's something that you'll still have strategies in place if you already have a good background in behavioral therapy when you're younger, or you keep an open mind about behavioral and talk therapy, and you can live a very happy, successful life despite having tics and Tourette's. The one other thing that I didn't mention earlier in the talk is that, particularly in people with tics and Tourette's, learning what things make you exhausted, make you feel like you're overwhelmed, make you feel too stressed out, and learning how to plan your life so that you don't get overwhelmed. So having good time management, stress management, and stress coping strategies, and learning what are your body's needs for regular exercise and regular sleep schedule to feel at your best, will in turn allow you to feel better and live better with your tics, your Tourette's, and everything that comes with it. So I'm going to wrap up here now. We've got a few questions in the Q&A bar. And please go ahead and keep typing if you have questions that haven't been posted in the chat. So a little bit more about the rage and rage attacks. There's a lot of evidence that young adults, their frontal lobe, which basically puts the brakes on when people start to get that fight or flight response and feel like they need to react and react strongly to a situation. Being able to put the brakes on that comes from the frontal lobe. And there's this pruning in your frontal lobe where your connections from your frontal lobe to the rest of your brain become more and more efficient into your young adult years and all through your 20s. So I can definitely remember being a lot more impulsive, even particularly when driving or with other risky behaviors when I was in my 20s than I am in my late 40s. And I think this is important because it's also true that men take a little bit longer for, particularly for those behaviors, for their frontal lobes to mature. And learning from those talk therapy approaches how to recognize when that's happening and still dial it down and dial it back still applies, whether it has to do with rage and rage attacks, problems with severe anxiety and OCD, or problems with depression. Cognitive behavioral therapy and insight-oriented talk therapy is so important for all those comorbidities. Suicide is something that was in the slides, but I didn't talk at length about. And there are a couple different scenarios where it's very important that we go straight to calling the crisis line. And we have a national hotline. You can type it in your web search and find the national or the local crisis line. Anytime that you or someone you love is at the end of your rope and you feel like you can do something you might do something to hurt yourself. Don't wait for other people to show concern. You can't wait on that. It's important that we always start with the crisis line and talk through how to approach that and what are your resources to help you get back from that cliff's edge. People with tics and Tourette's, because they're more likely to have comorbidities and they're more likely to get depressed, having all these things going on in your life is a big stress. They are also more likely to sometimes have these thoughts. They also may be a little more impulsive. So it's really important that when you or someone you love starts to feel this way, that you call that crisis line and get help. And then keep an open mind that if you're just seeing a neurologist or a pediatrician or a primary care provider, we're going to need you to also see a mental health provider, because it's going to be a team effort managing the tics and the Tourette's. Diet and exercise, I think everyone's very different in terms of what lifestyle approaches work best for them to feel at their best. Some people definitely feel that certain diets do not work for them. So I'm, for example, someone where a low carb keto diet, I will be hangry all the time. And so keto is not for me, but it may work really well for some people. There's no one diet that we can say can be tailor-made to everyone with tics and Tourette syndrome. But having a healthy diet and being able to separate hunger from stress eating is going to be really important, particularly if you start medicines where weight gain is the possible side effect. And that can be true of some of the newer antipsychotic medicines. The recording is going to be available through the Tourette Association of America, and then on their social media page and through their email blast. You should be seeing more information. You'll hear about this again at the end. Another challenge is when people have that involuntary either cursing or rude gestures, so coprolalia or copropraxia. So that's something where it often requires a combination of behavioral therapy strategies, sometimes talking earlier about the stronger medicines, and then also talking earlier on with the schools and getting education for the teachers and the classmates so that they are already aware of what Tourette's is and what it isn't. We have a youth ambassador program through the Tourette Association where young people are trained on public speaking and will go to schools and provide education to the schools and the teachers about Tourette's. Now, if you don't have CBIT in your area, there are also online approaches like tichelper.com, for example, that allow you to do a modified version of CBIT at home at your own pace. Most regions, but not all, also have CBIT specialists that can do telemedicine, but we want to choose carefully who does telemedicine in order to access that CBIT expert in your state or who's licensed to see you in your state. Because some young people just don't do well. They're not able to focus and do the therapy properly if they do it by telemedicine. When to change medicines, because people often notice improvement as they get older, it's okay to experiment with under supervision of your prescriber with dialing back tic medicines. But if the tics continue to worsen or they wax and wane, and there are some bad periods, you may still need to go back up on the dose or restart them later on. So we're right at the hour of 11 o'clock. And I know there are a lot of great questions that have come through. Not all tics or not everything that looks like a tic is just a tic. And one thing I'll finalize by saying is the role of the speech and occupational therapist is really important. First of all, occupational therapists are often your CBIT experts in the region, but speech therapists are really important to involve if you have issues with stuttering, because some tics involve having to repeat the word over and over. But if it's clearly stuttering and not just a tic, then early intervention with speech therapy can be really, really helpful. And the earlier, the better. All right, so I'm going to wrap up and hand it back over to our hosts and just see if there's any further comments on when and how the recording and slides will become available to the audience and to the public. Thank you so much for having me.
Thank you again for an excellent presentation. For everybody on this webinar, this is all the time that we have for today. We appreciate your patience getting started earlier. Once the webinar is ended, you'll receive a survey on the presentation. We would greatly appreciate it if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view the recording of the webinar. Additionally, the webinar will be posted on the TAA's YouTube channel for those who are unable to participate today. We encourage you to reach out to us about this webinar or other ideas and suggestions you may have. On behalf of the Tourette Association, thank you again for joining us and for taking the time to view our presentation. Have a great day, everybody.